Welcome to a new edition of Talk Medicine. My name is Dr. Alex Cahana, and I'm the Chief of the Division of Pain Medicine. Today I'm excited to talk about the Center for Pain Relief at the University of Washington Medical Center. At the Center for Pain Relief, we are committed to predict, diagnose, and prevent pain from becoming a disabling disease. At the center, we manage different types of patients with different types of pain problems. First, we listen to our patients and establish a diagnosis when possible. Then we think together about a treatment plan. Our treatment can include many things: image-guided procedures like selective nerve root blocks, occupational and vocational counseling. We can look at alternative medicine and medical management. Today we're going to concentrate on one aspect of the treatment, and that is medical management. With me, I would like to present my dear friend and colleague, Dr. David Tauben, who is Associate Professor at the Center for Pain Relief at the University of Washington Medical Center. And perhaps we'll start with a simple question, David. What is pain?
It's a simple question with a complicated answer, of course. Pain is what the patient says it is. And that's the biggest problem we have in managing pain and understanding pain, is because we don't have a simple test. There's no special x-ray, special imaging device. That is only what the patient tells us.
I was reading recently, there came out a survey that 3 out of 5 people actually say that they have pain that is so intense that they can't live a normal life. And in another survey, when they asked doctors what do they think about their patients when they complain of pain, they said that they are wimps, crocs, and fakes. And then when they asked patients about their doctors treating them their pain, they said they are quacks, hacks, and thieves. What's going on?
It's a frustrating aspect of medicine. I've been in primary care medicine for most of my career, as well as pain medicine. And as a primary care doctor, that indeed is the reason people come to see the doctor. Something hurts. Some people come in for annual checkups. Some people come in to have some spots checked on their skin. But most people see the doctor when they're upset. They have pain. They don't know what to make of it. There's anxiety about the pain. There's concern about the pain. And it's our responsibility as both primary care doctors and, most importantly, as pain specialists, to be able to explain to the patient what the pain is coming from, what the pain is doing, and what the pain means.
You know, it's interesting you say that, because in all the patients that I've seen these last 20 years, they always say to me 3 things. They say, "Doctor, believe me, my pain is real." They say, "If I would have known that the surgery would turn out like this, I wouldn't have done it." And they said, "Just take away my pain and everything will be fine." How do you start this whole discussion with the patient who has pain?
First is to listen to the patient's story. The biggest job of the pain doctor, and actually any physician evaluating someone for pain, is to listen to the story, not look at the tests, not look at all the imaging, not find out what other people have said, but take the story directly from the patient, because they will lead the careful listener, the careful doctor, most often to the source of the pain, be it in their head as a headache, their neck as neck pain, their back as back pain, the 3 most common reasons we see people for pain.
It kind of, actually coincides with what we defined as the mission statement of our center. We define it as that we are committed to predict, diagnose, and prevent pain from becoming a disabling disease. In a sense, predict. We know that today we are able, through different tests, maybe through genetics and certain personalities and questions that we ask, kind of get a good feel of what the patient is all about. We're able to diagnose. We have modern technology where we can actually come and pinpoint from where the pain comes from in some cases. And then also, of course, prevent pain, not so much of not having pain at all, but from becoming a disability. Tell us a little bit about what are the things that we can do at the Center for Pain Relief when a patient walks in?
I think the most important thing we can do, Alex, is to be able to trust the patient, believe that the patient is telling us their individual problem, and that their individual problem has great concern to them. It is often ruining them. Their lives are taken away. Their ability to carry on with their jobs, importantly, their family life, their important relationships, often ruined, if not ruined, on the way to that ruin. Often they're given scary diagnoses. They're put through expensive and sometimes risky procedures, often have surgery, and many times they come out worse than they started. It's very frustrating and they're very angry.
You know, that reminds me of when I teach students, you know, I always use the ABCs, you know, so A is ask the patient, you know, B, believe the patient, C, choose the right thing to do, D, well, you know, is drugs, and E is to empower the patient to take care of themselves. Are you trying to tell me that medication and surgery is not appropriate when you have pain?
Well, of course not. I'm a physician. We use surgery, we use medications, we use all sorts of modern technology to provide pain relief and to get to the diagnostic problems. The difficulty is knowing which medicine, and not only which surgery, but which patient will respond to which surgery, and when surgery must be done. Often, and in fact, most frustrating is when a patient comes after they've had this surgery. They have a problem, they see a surgeon, and my surgical colleagues are at the UW phenomenal surgeons. But often they should see the pain doctor before it becomes a post-surgical pain problem, because there are techniques, treatments, interventions, and drugs that can often prevent the first surgery from ever happening.
Interesting. It kind of now explains why in the Center for Pain Relief we have so many professionals under one roof. I am an anesthesiologist who specializes in interventional pain. Your background is in internal medicine and primary care. We have psychiatry, psychology, neurology, physical medicine and rehabilitation. We have access to exercise center of the University of Washington Medical Center. We have access perhaps also to other alternative therapies. So it's really kind of a combined solution for something that is very complex. When you say that, you know, we see them too late, it kind of reminds me of when you go to the cardiologist. I have a chest pain. I see my primary care doctor. I don't feel well. I go to the cardiologist, and he works me up, and he does some tests, and we obviate the need for surgery, perhaps. And it seems to me like when you have low back pain, then if you fail 2 Advils and 2 massages, the first thing you do is you go and have surgery. Why is that? Why do we want to take so many drugs, and why do we're so attracted to surgery? Is it something special here?
I think there's a belief system that if only the doctor could find the problem, my pain will go away. Unfortunately, that often doesn't occur. And certainly that is the population of people we see at the UW Pain Center, and the pain centers everywhere will encounter people whose pain just doesn't go away. And that creates many degrees of anxiety, and a very complex problem ensues.
So what you're saying actually is something very important that I'm not sure that many patients, but even many doctors know, that there is a difference between pain as a byproduct of a disease and pain, I would call it pain with a capital P, that turns within a disease within its own. So if pain becomes a disease within its own that really changes the way we are, what do we do? What is the recipe to kind of get out of this?
One of the most fascinating discoveries, I think, as you well know, over the past 5 and 10 years, is that pain for longer than 6 months changes the brain. So pain in the back, pain in the neck, after 3, 6 months, certainly after a year, is no longer just pain in the back. It's the brain is processing the pain differently. So in order to undo the ravages of that pain, one has to go to the brain, to the larger whole body experience that the person's suffering with, and begin to take the layers off the onion, as we say, and begin to explore the multidisciplinary, as you've discussed, aspects of the pain. It's a pain with a capital P. It's no longer in the back.
This is very exciting. I think that you really touched on that, the research that we're starting to do, trying to understand pain as a phenomenon that is happening in the brain. And you know, people forget that the first pain clinic in the world was actually here. John Bonica started it in the late 50s. So we're carrying a very heavy legacy. And I think that not only the Center of Pain Relief, but also the discovery that comes behind it, and trying to find what does pain do to the brain is extremely interesting. Do you have any patients in particular that kind of you recall of how you think pain changed who they were and their brain?
Well, many. In fact, I can just relate a quick anecdote here. Just a few days ago, a woman who I've known for many years, and we've done a very nice job taking care of her pain, mostly with medications. She's had a number of surgeries. And she was describing not just how it had changed her brain, but how it had ruined her life. And her constant prejudices that she had encountered by seeing many doctors who were afraid of pain because they didn't fully understand it. Now I would say, why would a doctor want to take care of a problem that he or she doesn't understand? And so the doctor reacts negatively to your introductory remarks about the way doctors perceive patients. Her comment was to me, she didn't understand why no doctor would take care of her. Just because I have pain, they will not see me. And yet the medicine she was taking had her functioning completely and fully. She had a full and enlivened existence with a family and a career, a publisher of books, yet she encountered a resistance to her condition that was overwhelming. She found the understanding that you got in my care and the care of the pain center, an opportunity to be evaluated for who she was. And that in itself relaxed the brain and allowed her to process the experience a lot more normally.
So pain is tough. Pain is tough for patients, of course. They are isolated and all by themselves. Pain is tough for doctors because we don't know what's going on. And maybe pain also is tough for society because we really don't know what the right thing to do. And we conflate between pain and suffering. And I always say that if they would teach me in medical school the difference between pain and suffering, or maybe how they're interlinked, and I would be able to really help. I think that is something that's great, that we have so many professionals in our clinic able to listen and to offer different tools and offer, I would say, a complex solution to a complex problem. I'm always very weary when people offer me simple fixes for something that is so complicated. You know, David, a recent study showed that 80% of patients who seek medical assistance and see doctors suffer from pain. On the other hand, they wait until they see a pain doctor, they wait between 5 to 7 years. We have with us Mr. John Milchenko, who actually waited almost that long in order to see you. Can you kind of tell us a little bit about the meeting that you have with Mr. Milchenko?
Yes, well, John and I do go back many, many years. And he was sent to me by one of the physicians here at the University of Washington after John had his neck surgery and asked him to see me in order to try to find an answer to his neck pain that was so disabling and so troubling. But rather than me tell the story, because John's story is his own and the one we need to listen to, John, why don't you describe what your experience was before you saw me?
In 1983, I was injured in a commercial fishing accident, and I was weakened but not knocked out. So everything was fine for about 6 years. And then I started having pain in a shoulder and had that fixed, and it was fine for a couple of years. And 2 years later, I had the same pain in my other shoulder, and I kept going to doctors and hospital emergency room twice, and they never could. Everything seemed normal, but I still had all the horrible pain, and I could get a little bit of help from this doctor, but they didn't. Nobody wanted to take care of me.
And so did you have an idea what was causing your pain at that time? Did the doctors have an understanding of what the pain problem was?
I knew it was something with my neck because of the way it was, but I had had a few MRIs and x-rays and nothing happened. They didn't see, everything's normal, so I got, I think, labeled a drug seeker. And finally I got to one doctor that did a MRI with contrasting fluid, and they saw I was missing a couple of discs, and it's like, oh, he does have problems.
So they found out that something is wrong, and then you went to see Dr. Tobin.
No, I actually had 2 neck surgeries.
Oh, wow. So they found that something was wrong, so you went to a surgeon. And what did the surgeon say to you?
He said this should make it better. There again, no guarantees, but it was a better chance it would be better than not. So we went ahead and had surgery.
And what happened? What did the surgery make?
First surgery was unsuccessful. Bone graft didn't take, and they put a halo on me and had a second surgery, and the Surgery, I guess, would be successful on the standpoint that my structure's fine, but unsuccessful that my pain was still there,
And what was
and at times worse.
Was it the fact that your structure wasn't right bothering you, or was it the pain that was
The pain. Yeah, and even after the surgery, they said everything's fine, nothing's pinched, whatever pain you have, it's in your head.
Is this something that you ever heard before? Patients saying that, everything's okay, but I still have pain, so it's all in your head?
Unfortunately, it's a common story, so it didn't take a lot of faith to know that John had neck pain and John deserved treatment, and John needed to be treated with prejudice and distrust, which is a big problem that he was having.
So John, why don't you try and bring yourself back to that first meeting. What were you thinking as you were walking in the door going to see Dr. Tobin? What were your thoughts?
Well, a little apprehensive because I'd been dealing with this for 5 years, had seen a number of doctors, and always, I guess it was being labeled as a drug seeker. They wouldn't, not saying that, but in as many words, didn't have to be said. And I was just thinking, well, I hope I can get some relief here.
What did Dr. Tauben say to you, or how did he kind of gain your trust that you say, you know what, let's go ahead and do this? What was so special about that meeting with Dr. Tauben?
Well, just the fact that he listened, and we're very open about everything, and he didn't, make me feel like I was trying to do something behind his back. I mean, things were very clear up front that he was going to be, in control of what I did, and if I needed medication, I could get medication.
How did it feel to finally see a doctor who gets it?
It was unbelievable. I don't know if I can even express it. It was just after the years of I can't even remember how many doctors I've been to be able to just see one and know that I only had to see one, and he would take care of any issues. Because we've tried many different things to keep the narcotic pain medicines down to a minimum, and it took probably, I would guess, 5 or 6 years before we got to the point where I'm now on cruise control. But,
David, you got to tell me, what do you do so special that you're able to capture that trust in people that have clearly a very negative medical history?
Believe them. And John has a believable problem. He's a believable person, and he meets pain medicine criteria for receiving treatment.
So when you construct, let's say, a treatment plan, what are the elements that you put in that treatment plan? What's your recipe of that pie?
The treatment plan, of course, has to be individually adjusted. The person has to be a individual with a problem that needs no further diagnosis. If John had a problem that needed more testing, we would need to do more testing. At that point, he was fully evaluated, and it was clear that there was nothing more that was available to medical science at that time. And unfortunately, still to this time, 15 years later, there's still no cure for the persistent pain problem. John also, and other patients, need to respond, and they need to respond favorably, and he had a very favorable response. He didn't have any adverse effects from the medications. And these are working man's hands. There's no question that this man functions. He's full of scratches and calluses, and even some paint he couldn't get off. So there's no reason to challenge the fact that John has been productive and he continues to function well. So absent side effects, favorable response to the treatment, no adverse effects, and a true quality of life that's been returned to him.
I think that not only patients, by the way, I think a lot of doctors really confuse between acute pain that is associated with injury, the broken arm, with some type of acute problem, and chronic pain, when it's a disease on its own and it stays there. And they hope that they will, if they stop the medication, things will be fine, as if it's kind of, you need to do that. I don't remember in hypertension, if you have hypertension, you take medication all your life. You don't stop it when the hypertension is controlled. Is that something, a misconception that you've seen before?
Well, particularly with the pressures that patients have to not be on pain medications. They themselves don't want to take chronic medications. I don't want to have to give chronic medications. In the best of all worlds, it wouldn't be necessary to ever have a patient in pain. So people struggle with the concept of having to take a medication every day. Even hypertensives have trouble taking a medication every day.
And David, do you know this? Is this known? Is there a stigma or a phobia or some concerns maybe that have to deal with the fact that we're prescribing medications that create some stigmas?
Well, it is a problem, and it's a legitimate problem because there is abuse of pain medications. There's abuse at many levels of pain medication taking, but there's a legitimate and a very valuable effect that pain medications have. They relieve pain. They can cause problems. So the duty and responsibility of a pain physician is to recognize when it's helping, how it's helping, prove it's helping, and if problems develop, identify those problems, manage those problems, and respond to those problems. And in John's case, he went through the evolution of all those experiences. He himself was concerned about a problem. His wife was concerned about the problem. He tried off, he tried on, and at this point, he's, I think, a testimony to the fact that proper management will be able to give him his life back.
So I think that many times we confuse suffering and pain, which is, of course, very intimately linked. You know, I have patients that have MRIs and on their exam and diseases that I say, you know, oh my God, how can they suffer this? And they're just, you know, sitting there. And I have others that I have to look with a microscope to try to understand what's wrong, and they're just screaming their head off. And it kind of makes me think of what is the definition of suffering. And, you know, I was thinking of my 3-year-old who wanted to go out and play, and I said, you know, first clean up your room and finish your project, and then we can go out and play. So she was cleaning and doing her stuff and this, and then after she said, let's go out and play, and I said, it's too late. It's too late, let's brush our teeth and go to bed. And think of the intense suffering of the unfulfilled promise. And I'm just trying to think of the promises that John had, that, you know, it's fine. If you'll work hard, things will be fine. And, oh, the neck pain, that's nothing, it's fine. And the surgery, you'll do it and it'll be fine. And the disappointment, one after the other. And the suffering just going one on top of the other, that nobody really believes that you actually have something.
Well, John also has a family, and his inability to fulfill his expectations of being the good father that he is, and the good husband that he is, and the career that he enjoys his work, he takes great satisfaction in his work. Those are other components of the suffering that people have, the unfulfilled promises of their lives. So to restore someone back to life, to relieve the pain, really does address the suffering. But indeed, they are two separate elements that need to be teased apart.
Well, you know, I really want to thank you, John. You have a remarkable story, and you know, again, I commend you for just moving ahead and continuing to be productive and functional. And of course, David, what can I say? Every day, what you do, and if only I could clone you to many more Davids. So again, gentlemen, thank you very much for this wonderful conversation.
Thank you.
Thank you.
I am Dr. Alex Cahana, and thank you for joining us on another edition of Talk Medicine.